February. Welcome everyone to our February Neurohumanities Network seminar. Just as a reminder, we are a group of neurologists who are really interested in the intersection between the humanities, the arts, and the neurosciences. Our group is made up of three trainees and neurologists, myself, Charlie Palmer, Galina Gaiman, and we're so fortunate to be helped by two wonderful med students, Jay Doolittle and Connor Lewis, who are really the minds and the hearts behind our newsletter and our social media presence. We also want to acknowledge and thank the support of the Arts and Humanities Initiative at Harvard Medical School, who are providing a generous grant for our group. We, in addition to these monthly virtual seminars, an example will be today, we're also trying to build a community, a third space for people interested in this interesting intersection. And we do so via a monthly newsletter, YouTube channel. We're also present on social media, including Twitter, Instagram, and Blue Sky. In addition to the virtual seminars, we also have some more practical booster sessions. And one example of this will be announced at the end of the seminar today, so stay tuned. We are also having a website in the works, so stay tuned for that as well. We are extremely excited to welcome today Jesús Ramírez-Bermúdez, who's a neuropsychiatrist, who's a graduate of the National Institute of Neurology and Neurosurgery in Mexico. He's also the director of neuropsychiatry and cognitive neurology at the same institution. He has published more than 100 research articles exploring the cognitive, affective, and behavioral aspects of brain disease. His projects are promoting a transdisciplinary approach to mental illness, which integrates the narrative arts, the humanities, and brain science. All of this, it should come to no surprise to this group, is exactly what we're striving toward here. He has published several books that combine elements of the creative essay, scientific thought, and clinical narratives, and his contributions have garnered him international recognition, including awards such as the award from the International Neuropsychiatric Association in Australia, and many, many more. His lectures have also been featured at the Jean-Nicot Institute in Paris and the British Neuropsychiatric Association in London. Without further ado, Dr. Ramirez-Bermudez, take it away.
Well, I'm very excited to be here. Thank you very much for having me in your wonderful network dedicated to arts and humanities. I think that it's very necessary for us in the field of medicine to have those kind of projects and spaces, because well, I'll be talking today precisely about the problem of medical reductionism, which is no doubt an important problem, one that has been criticized in many ways, and it is a fair critique. In fact, patients make that critique, and also many colleagues from different fields. So I think that we need a multidisciplinary approach, a transdisciplinary approach, if possible. And I'll be trying to speak about that today. I will be dealing with this article, which is entitled "The Clinical Narrative and the Painful Side of Conscious Experience." It is a paper that I wrote with Jimena González Grandón. She's a philosopher and also a physician. She delves into the enactivist and embodied cognition approaches, which are very interesting because it connects biology with phenomenology. And also Rosa Aurora Chavez, who is part of the George Washington University. She leads a center for creativity there. And she is also a psychotherapist within the psychodynamic tradition. So I hope that the article as such has that kind of transdisciplinary flavor that we're looking for. So this is going to be the program for today. It is somewhat ambitious, perhaps. I hope that I can go through at least some of the details, and that it will be interesting for you today. I will talk a little bit about the transepistemic approach to mental symptoms. Then I will try to provide a phenomenological journey through neurology and psychiatry through three examples. One of Cotard delusion in the context of a patient with schizophrenia. Another one is a case of a patient with delusions of bodily ownership. And the third case is about a patient with Anton syndrome, a problem of visual anosognosia. Then I will try to delve into the problem of clinical narrative through three approaches also. The first one is clinical narratives as a form of medical report. The second one is clinical narrative and the experience of psychotherapy. And the third approach will be clinical narrative as a literary genre. So at the end, I will try to provide some sources for this concept of intercomprehension and epistemic pluralism in phenomenological psychopathology. Surely you are aware of the movement of phenomenological psychopathology, which is of great interest, a renowned interest. It is a tradition that starts probably with Karl Jaspers, the famous psychiatrist and philosopher. He was, as known, a student of Martin Heidegger. But myself, I prefer the approach of Karl Jaspers because he was informed by clinical practice. He was a clinician. So it's not merely a theoretical enterprise, but in fact, it is a clinical approach that is grounded in philosophy, and a philosophy that is grounded in clinical practice. And from there are of course many approaches that we are interested in. The more recent approaches by Humberto Maturana from Chile and Francisco Varela, who have started the movement of enactivism, but also the more recent approaches from different philosophers and clinicians, like the recent movement in England mainly. There are recent projects in phenomenological psychopathology, even neuropsychiatric phenomenology. So, well, let's get started. I must apologize also because of my English is a little rusty, like you can see, but I hope that this will improve through the presentation. So the scientific study of consciousness offers unexpected opportunities for a trans-epistemic dialogue. We've all seen that in the recent decades, there are many research programs dedicated to consciousness. The programs of predictive processing, the global neuronal workspace, the integrated information theory. There are many debates in that field, no? Coming from computational neuroscience, for instance, no? But also there is a big debate in the field of philosophy, where we can see every day the great debates between people like David Chalmers or Mark Solms, for instance. And I think we can learn a lot by listening to all those debates. But personally, I think that these debates need to be informed by the problems that we see in the clinic. Because, in fact, those of us who are in the fields of psychiatry or psychotherapy, neuropsychology, or cognitive neurology have access to the most mysterious, amazing, enigmatic problems that concern the problems of consciousness. So at the same time, I think that we need this science, the science of consciousness, to solve many of our own problems. So most clinical problems in psychiatry and cognitive neurology involve atypical, distressing, or painful subjective experiences. And often we frame these experiences as psychopathological phenomena. However, even if we choose to avoid the language of pathology, because certainly some clinical traditions avoid the language of pathology, even then, we would need to recognize that these experiences involve important degrees of suffering, harm, disability, or even death. And the study of consciousness, in my view, requires scientific methodologies, but also we need a comprehensive understanding of the qualitative dimension of this that I will call the painful side of consciousness. Because I don't have a better term. And that is something that perhaps we can discuss. And I would be willing to listen to your own approaches. Perhaps we need different metaphors. Using the terminology of pain is, of course, a metaphor to refer to suffering and the different kinds of phenomenological experiences that we are going to analyze. So for the moment, I will go on with using this metaphor, the metaphor of pain, mental pain, as some psychoanalysts use the term, or even, there are even some neuroscientists that use the term social pain. But well, we can discuss this properly in a few moments. Anyway, I think that these experiences have a qualitative dimension because we don't have any technology to make a quantification of subjective experience. We still rely on a qualitative approach that is perhaps formatted by symbolic languages. So the verbal languages, but also other symbolic resources are those that we use to approach these qualitative experiences. And we don't have another kind of a better approach to this. We don't have quantitative electrophysiology or even a quantitative functional magnetic resonance imaging to model these experiences. So we will rely on this qualitative dimension. And this qualitative dimension leads to a narrative approach and to a hermeneutical approach. And I think that the narrative practices are indispensable because they allow us to account for the dynamic fluctuations in phenomenological experience and its relational and historical nature. What I mean with this statement is that as clinicians, we are used to say, for instance, that a patient has delusions or has hallucinations. But in fact, if we make a detailed account, we will see that the hallucinatory experiences increase or decrease in intensity, in severity, that they have changes when we are around or when we are not around. When we make a psychiatric interview with our patients, this phenomena also undergo certain changes. So there are dynamic fluctuations because these are temporal phenomena. And I think that the narrative practices are the best way to make a fair account of these temporal fluctuations. So in the last years, we've tried to make a formal approach to the philosophy of neuropsychiatry, because in my own institution, the National Institute of Neurology and Neurosurgery, we see patients with neurological disease, for instance, brain tumors or encephalopathy due to the COVID virus, or leukopathy due to the use of drugs or viruses, or we can see also many patients with autoimmune conditions. So we need to speak the language of neurology and clinical neuroscience. But also we see patients with psychotic depression, with complex trauma, with patients with bipolar disorder or schizophrenia. So we also need to speak the language of psychiatry. And when we try to put together the different kind of problems, we need an all-encompassing theory. And this theory relies, in my view, in clinical neuropsychology, cognitive neuroscience, psychotherapy, internal medicine, affective and social neuroscience. So it is really interdisciplinary project, the project of neuropsychiatry. But then going through the clinical cases, sometimes we get involved with the patients for many years even, or we see the problems with their families, the problems with their couples, with their sons or their fathers or mothers. And we understand that the clinical picture is only a part of a larger story. And we think that this larger story can be captured with the tools of creative writing, literature, narrative practices. So sometimes myself, I do this kind of exercises of, for instance, at the left of the slide, you can see a novel that is a clinical novel. The second book is a literary essay that is written as if it was a dictionary, but it is not a technical dictionary, but instead it is a literary dictionary in which we can find clinical cases, but also some resources from poetry or literature. And sometimes clinical practice takes us outside the hospital and into the realm of social environments. For instance, this book, A Dictionary Without Words, is a book about three female patients who lost the language completely because they had problems of aphasia, sometimes due to traumatic brain injury or sometimes due to a viral encephalitis. But anyway, the problem here was trying to understand how they were trying to survive in a very difficult society like the Mexican society, not the touristic side of the Mexican society, but in fact the neighborhoods that have more violence, more economical problems. So how do these patients survive in those environments? How do they work and even earn money if they have no words to express themselves? So those were the problems in this kind of novel. So in a way, this paper is like some kind of ars poetica, no? Using the term by Jorge Luis Borges, who has this wonderful poem, the Ars Poetica, no? In which he tries to provide some key features of to understand what makes a clinical tale, what makes a poem, what makes a literary essay. So this article tries to explain this problem, the problem of clinical narrative. So as I said before, we are using pain in a metaphorical way because we don't have better words. Some people speak of mental pain. For instance, Christopher Bolas, a great psychotherapist, uses this term, or emotional pain, social pain. Dr. Naomi Eisenberger from the University of California uses the term social pain when she models the kind of emotional pain that emerges from social disruption. Sometimes words like woe or affliction or distress can be used. But anyways, I will be using the term the painful side of conscious experience because I think that the science of consciousness needs to explain these problems. Perhaps it's even the strongest ethical foundation. I think that scientific curiosity is enough to explore the problem of consciousness. But from an ethical perspective, these are important problems for which we still don't have full understanding. So I will try to provide integration of mechanistic subpersonal models. I am using here the terminology by Daniel Dennett, a philosopher, who speaks of subpersonal problems and personal problems, right? So the personal problems are those that we can express in a language of popular psychology. For instance, when I say that I have a desire, or that I am thinking something, I am using the resources of popular psychology to express myself. But when I use a mechanistic model, a subpersonal mechanistic model, I will speak in terms of the electrophysiological activity of a neuron, for instance, or the dynamic coupling of neuronal networks. And the great problem, of course, is how can we put together those two different dimensions, the personal and the subpersonal dimensions? How can we put them together or explain each other in a mutual understanding of the phenomenological and hermeneutical level of discourse and the level of neuroscience? So these are the kind of clinical problems that we see and that I tried to express in this paper. This is a discourse of a patient with a delusion, Cotard's delusion. It's very difficult to understand this discourse, uh, but I didn't change it for poetic purposes. I just make a transcript of what the patient was saying. No? So he says, I am Marco Antonio. I died when I was still a baby. My soul was absorbed. And then all of this human physiognomy began. I became a phytocultivator. Who or what absorbed me? I don't know. Well, in fact, as you can see, the patient is having um, many resources in his discourse. It's very difficult to make a symbolic interpretation, or should we do instead a deconstruction, neuroscientific deconstruction of this kind of discourse? Should we seek for a interpersonal understanding of this discourse? Should we do both? So these are the kind of questions that we try to answer. Uh, on one hand, we try to provide an explanation, perhaps a neuropsychological or neurocognitive explanation, but on the other hand, we need an interpersonal understanding of the problem of the patient. Now, of course, this will lead us to different models of psychosis, phenomenological models of psychosis. The exploration of subjectivity, I think, that allows us to establish a dialogue based on personal meanings. What do I mean with this? For instance, the patient speaks repeatedly about a woman who was born at the same time as he did, and they knew each other since childhood, but she died recently. So this opens the opportunity to explore his feelings of mourning. Now, the relatives tells us that this woman does not exist. Factually, she does not exist. It may be a case of delusional mourning. Nevertheless, exploring this feeling allowed us to build a therapeutic relationship based on affective attunement. So we don't just merely go through the patient making a syndromic diagnosis or a DSM diagnosis, telling the patient that he has the symptoms of psychosis and schizophrenia and so on. But we try to understand the symbolic meanings that could be not because we think that perhaps we could have a full explanation of the genesis of the symptoms, but instead because this gives us opportunity for this affective attunement. Now, this is a different case. This is a case who has a kind of delusion. I don't have an exact name for this symptom, Of course, it resembles what we see in cognitive neurology, which is the cases of somatoparaphrenia, right? But somatoparaphrenia or asomatognosia are conditions that appear after a patient has a brain lesion, typically in the right hemisphere, perhaps in the insular or parietal cortices, and in which the patient loses the sense of ownership of their own body only in the left side of the body, right? The left arm, the left leg are those that are affected. In in this case, it's something similar, but it's not lateralized, and there's no brain lesion. At least we cannot see any brain lesion with the resources of an MRI. So it's a case of schizophrenia. This patient was brought to the hospital, restrained, chained by his family, and we will call him Juan Manuel. He insists on gouging out his own eyes, and once he nearly succeeded, he severely injured his eyelids and eyeballs. So that's why the family restrains him. And of course, this is a delusion. We were not able to solve this through psychotherapy. So in fact, we didn't have success with most antipsychotics. Only with the resource of clozapine, we succeeded after many months of a very dramatic situation. And I've seen him for 15 years now. And recently, we had a problem of lack of access to clozapine during the pandemic, and the patient had a relapse of these very dramatic symptoms and these attempts to extract his own eyes. Now, this is the problem, no? And first, I would like to make some sort of reflection, no, that the kind of problems that we're dealing here are not trivial concerns, no, not at all. And these are not merely like some academics say, no, like Thomas Sass, who would say that there are no real mental illness. We only have problems in living. Well, from my point of view, the problem of this patient is not merely a problem in living, like a divorce or something like that. This is really a very dramatic illness. Perhaps we don't have a full understanding of the etiology of this kind of illness, but it is a very severe illness with a lot of distress, a lot of suffering, and a lot of harm, of course. Now, the third case that I want to present is this case of anosognosia. So this is a man with a subarachnoid hemorrhage. And after this, he has, as you can see, a large lesion that is affecting the right hemisphere. You can see in the MRI below, we can see a flare sequence and also a T2 sequence. The first two in an axial projection, the later one in a coronal projection. And you can see that he has a chronic brain lesion that is affecting the frontal operculum, the insular cortex, both in the anterior and posterior parts of the insular cortex. And also the lesion is affecting the temporal and parietal lobes as well. And there's a bilateral lesion in the occipital lobes. So this bilateral lesion in the occipital lobes has the functional effect of this is a case of blindness, of course. So the patient is completely blind, but he has a persistent discourse according to which he can see. So first we should try to figure out if it is a case of confabulation or visual hallucination. But in any case, there is a problem of anosognosia here. So the patient has a visual anosognosia, and as you can read in the paper, it is also very dramatic in a way for the family, because he is even aggressive towards the wife, because she doesn't want to give him the keys of the car, and he wants to go and use the car to buy different things in a store nearby. So well, this of course is a legal problem, an ethical problem, and once again we have here a phenomenological problem that for which we don't have a full explanation, a behavioral problem, a cognitive problem, and certainly a neurological problem. And we need to put all those features together through probably a neurocognitive model. But now this neurocognitive model, perhaps we can rely in some recent research like this Bayesian model of Anton syndrome by Pollack and Corlett, in which they think that top-down visual percepts are predicted according to priors, but an impairment in prediction error minimization causes a failure in the person inference about their own blindness. So this impairment in prediction errors could be, in my view, due to a white matter damage that we saw in the patient in the right superior longitudinal fasciculus, leading to a dysfunction in the ventral attentional network. So I think this provides an explanation. This was a paper done by Katerina Fotopoulou, a wonderful neuropsychologist from the UK, in which she shows that this disruption, this disconnection, so to speak, in the ventral attentional network leads to a failure in updating the prospective beliefs about their own blindness. But we have a different problem, which is this doesn't explain exactly why the patient has, for instance, an aggressive behavior, specifically to his wife. He was never aggressive towards us, towards the clinicians, or towards other mental health professionals. He was aggressive exclusively towards his wife, and only when she confronted his authority. So even in this case, in which we have a neurological picture of the problem, even a neurological explanation of the cognitive dysfunction, we still need a psychological formulation of the case to understand these emergent behaviors. So this is why I think we need an ideographic approach. So this leads me to the second part of this presentation, in which I will speak more about these resources, the resource of clinical narrative in medicine and psychotherapy, and as a literary genre. And finally, we will try to put this together in a pluralistic account of mental health. So, well, first, as you saw, I relied mostly on clinical cases because even if we, of course, use, and I use a lot of statistical methods, and all the times we are using clinical epidemiological approaches to neuropsychiatric problems to see the common features of many patients that have the same condition, for instance, autoimmune psychosis. We still need the individual level to understand the emergent behaviors that make specific problems for a patient. So I think that as clinicians, we always have to look for the common features that connect one case with the general knowledge that we obtain through scientific research, but also we also need to see the specific features of each case that we can only understand through case formulation. So, of course, case histories are as old as medicine. I was recently reading, for instance, some clinical cases that are depicted in the epidemics of Hippocrates, because I was looking for the oldest descriptions of delirium. And I think delirium is the oldest neuropsychiatric construct in which the same word is explaining the same condition through 2,500 years since the epidemics. Also, Avicenna in the Islamic tradition has wonderful clinical cases in his canon of medicine. Now, during the 19th century anatomopathological revolution, there was a renowned attempt to explain all the language of medicine with the resources of anatomic pathology, of anatomical pathology. And of course, all these words that we use today, agnosia, aphasia, amnesia, apraxia, were developed as some sort of medical resources to make sense of what the clinicians were seeing, no, in those days. And also the language of psychology developed, like Herman Berrios has explained in his wonderful book on the history of mental symptoms. So these clinicians were great storytellers. So they were wonderful storytellers, all of them. Kraepelin is a great storyteller, but also Griesinger, Charcot, Jules Cotard. It's really wonderful to read these cases, as they had no technology. They had to rely on clinical observation and narration. And increasingly, the writings incorporated details about the subjective experience of illness. For instance, in the earlier descriptions of schizophrenia, right, by Ewald Hecker, there are some letters written by the patients. So we have the access there to a first-person perspective from the patients. And as we will see later, mostly in the field of psychotherapy, the second person emerged. Well, but first, let me just go through this slide in which I tried to picture some contemporary works in this tradition of clinical narrative. Of course, Alexander Luria would be the modern father of clinical narrative, and Oliver Sacks is very popular, right? But also this wonderful British physician, neurologist, Andrew Lees, who wrote this amazing book, mentored by a madman, which is an experimental account of clinical narrative. Of course, the works by Antonio Damasio, Michael Gazzaniga, and so on. An interesting case would be here this work by Jill Taylor, because as you know, she was an anatomist. I think she was working there in Harvard, right, in Boston, and she had a stroke. I think it was a brain hemorrhage, and a large hemorrhage in the left hemisphere. So she was aphasic, and she had this strange mystical experiences that she could not communicate. So this is a first-person account in which the scientific perspective is mixed with the first-person account of these emergent experiences, which we don't know if they are mystical experiences or psychopathological experiences, right? Now, in the field of psychotherapy, which emerged very soon in the early 20th century, there were important advances here, and I think that we need to recognize the advances that were provided by Sigmund Freud, because I mean, I am very aware of all the criticisms to his work, but he advanced really the psychological formulation, and perhaps this was done through his case histories, the Dora case, and all the famous cases by Sigmund Freud, in which I think that the innovation here was not only the narration, but also providing a metapsychological model to provide an explanation. So here we have the narration, the interpretation, and the theory. Now, of course, we can discuss the theory, right? We should discuss the theory, but it was an innovation that led to different kind of resources. For instance, the resources by Francois Dolto here in his autobiography, or Margaret Little in this book, in which is her own memoir of her analysis with Donald Winnicott, the famous psychoanalyst. So these are other kind of narrations in which the second person emerges, because now we have the clinical dialogue, intimate clinical dialogue between the therapist and the patient, so to speak. So now we have the narrations that are done in third person with a third person perspective, a second person perspective, and a first person perspective. And we have all sort of works. No, I put here an example by Mark Solms or even Marsha Linehan, who is very critical of psychoanalysis and psychiatry. But what I am trying to provide here is a picture that when we go into the field of clinical narrative, we will find multilateral debate, pluralistic debate, in fact, in which we will find accounts that are consistent with psychiatric theory and accounts that are critical of psychiatric theory. For instance, in this book that I show here by the Brain on Fire, the very famous Brain on Fire, this wonderful novel by Susanna Cahalan, this journalist from New York, is very famous, and she makes a reinterpretation of the myth of madness through the resources of neuroimmunology and contemporary neuroscience, right? And other case would be here this book by Siri Hustvedt, The Shaking Woman, in which she goes through a personal testimony of a problem that perhaps 100 years ago would be regarded as a problem of hysteria, perhaps, in the days of Charcot and Freud. Now it would be a functional neurological disorder. I don't know if that is my preferred terminology, but anyway, it's a fascinating testimony and essay by a very gifted writer. So what I am trying to show here is that this tradition, the tradition of clinical narrative, will have patients and also mental health professionals, and the mental health professionals will be psychotherapists or physicians or neurologists or sometimes other kind of researchers. Of course, the most classical works here would be those by Gerard de Nerval, Aurelia, which is a very important work because it is a clinical novel that is not trying to be a fiction work. He's trying to make factual transcription of his experience, the experience that was captured by the clinicians of his day as an episode of mania. Of course, we all know that Gerard de Nerval unfortunately died of a suicide. So this work is, I think, very interesting for all of us who try to understand the subjective side of perhaps affective illness. And what about these other works by Virginia Woolf on being ill, or Diario del Dolor by Maria Luisa Puga? I don't think it's translated into English, but these are very careful essays and testimonies about the first person perspective of mental pain or physical pain. Now, beyond the value of clinical narratives as communicative tools for psychotherapy and for the culture of mental health, it is possible to conceive a meta-theoretical perspective about narration as a core structure of therapeutic experience. So this is something that we'll learn when we approach the field of clinical narrative in psychotherapy. So I will rely mainly on two authors for this formulation, Roy Schaffer and Paul Ricoeur, the famous French philosopher. So Paul Ricoeur postulates that storytelling has a transformative power because the pathos, the affective core of our humanity, no matter how deeply buried, shares a kinship with the communicative rationality mediated by language, the logos. So, uh, psychopathological states imply a breakdown of symbolic function, and the task of narrative therapy is to reintroduce the patient to the linguistic community by means of resymbolization. Psychological transformation is possible because human desire has a dialogical structure. It can be reshaped through therapeutic symbolization, which requires a long-term communication and attentive listening on both sides of the clinical relationship. So this forms a bidirectional interaction encompassing not only the verbal, but also the prelinguistic and paralinguistic aspects of communication linked to interpersonal affectivity. This is the second element of Ricoeur formulation. Now, the third element is that we establish relationships, not only in psychotherapy, but all our human relationships, based on desire, ambiguity, fantasies, and deceit. So Paul Ricoeur calls this the imaginary or phantasmal dimension that brings suffering. It may bring some suffering because sometimes it isolates us, or it may bring disappointment if we confront reality in a premature form. However, this illusory activity can be transformed to nurture creative imagination. For instance, in Thomas Ogden's view, symbolization leads to a co-created intersubjectivity through the interplay of words, sensations, imageries, and dreamlike states in the context of psychotherapy, giving rise to new emotional and conceptual meanings and a renewed self-awareness for the patient. That is his specific hypothesis that, of course, we can discuss. Now, finally, Paul Ricoeur stresses that we need to account for the temporality of our lives. And this process relies on the synthetic function that Ricoeur refers to as emplotment. This means configuring sequential events by means of a plot. And this function provides a coherent articulation of scattered events through dialogical storytelling. So what is the result of this process? So our patients may initially assume the role of spectators of their own lives. They are often perplexed by the randomness and the heteronomy inside their own histories. And through therapy, individuals gradually will reappropriate their own sense of authorship and responsibility, facilitating the restructuring of their deeply ingrained interaction patterns. Okay, so finally, I would like just to go through some key concepts of this paper. The first one is that as clinicians, we always need to rely on this transepistemic approach that lies on the first person perspective, the second person perspective, and the third person perspective. I think that clinical medicine shows us a lot about the third person perspective, which I respect a lot because scientific objectivity is faithfulness to facts, according to Stanford Encyclopedia of Philosophy. And I want to be faithful to facts, the clinical facts of my patients. So we need to always be in agreement with this ideal of objectivity. But we should never lose the first person perspective of our patients and the second person, which is perhaps under theorized and underdeveloped in medical epistemology and perhaps even in psychological epistemology. Now, I think that a full scientific and philosophical understanding of consciousness and health cannot be achieved without solving the kind of psychopathological problems that I depicted earlier. And by this, I mean that we need to understand the causal mechanisms, but also the relational features that sustain this kind of problems. So we are trying to argue for an epistemic project of scientific explanation that tries to bring together a mechanistic subpersonal model developed through the resources of neurocognitive psychiatry, but also to inform this model with the resources of a careful anamnesis, so to speak, the art of clinical dialogue. And I think that if we don't rely on this integration, we face an important problem, which is automatization. And also through diagnostic labeling, we can go. I mean, I'm not an enemy of diagnostic labels. I use diagnostic labels all the time, but my thought is that we should use diagnostic labels only after a careful diagnostic reasoning that allows us to achieve a diagnostic synthesis, and that synthesis may be the diagnostic label, but we also need to provide always a case formulation, because otherwise we can go through the process that we will call diagnostic literalism, a diagnostic literalism in which we literally think that the diagnostic label, just as depicted by the DSM or whatever diagnostic manual, is exactly what our patient has. We know that is not exactly the case. It's just the diagnostic label is just a resource for having some sense orientation around the scientific literature, right? But the third problem would be reification. And reification occurs when we fail to listen to our patients, when we ignore their subjectivity and reduce them to objects. So reification is complete when the abstract diagnostic construct is treated as if it were an object, a natural kind, or an ontological essence. So to paraphrase once again Germán Berrios, to reify means to view human relationships as if they were inanimate things, stripping them of all dynamism, meaning, or personal value. So myself, even when I approach patients with brain lesion, for instance, patients with a brain tumor or a stroke, they still require this feature of a case formulation in which we need to account for the social and psychological and biological factors that sustain the psychopathology. Finally, I think that to foster the mutual understanding between patients, families, and mental health professionals, we need to remember that we can approach we can approach mental symptoms through various lenses. We can see mental symptoms as symbols that require interpretation, which may be a symbolic interpretation, like the one provided by some different resources of psychotherapy. But also we can conceptualize mental symptoms as indicators of an underlying pathology without any personal meaning, without any symbolic meaning. Or finally, we can think that mental symptoms are constructed without contradiction through pathological processes that have that can be accounted through a mechanistic model, but at the same time, these symptoms have personal meaning or social meaning, and this needs a kind of interpretation. So I think that if we don't understand these nuances, we are in a way blind to this kind of errors, the type 2 or the type 1 error, right? So in the type 1 error, we go through a process of pathologization, right? We pathologize an experience that is not the result of pathology. So for instance, a person has a psychological problem and experience some form of sadness or grief, and I say that the patient has a biological problem of depression, no? right? So perhaps the patient doesn't have any disease, no? He's just going through a psychological problem. But the type 2 error is equally important, in which I fail to identify a relevant pathological process by relying only in psychological interpretation. So sometimes I had a patient, for instance, that his wife died, so he was in a process of grief, and I thought he had a psychotic depression as a result of mourning, grief. But in fact, he had a gigantic brain tumor, and I only diagnosed the case because the patient started having some cognitive problems. So in that case, it was the sensibility to these cognitive symptoms that allowed us to diagnose a brain tumor. The patient certainly was unlucky at that time. So these are the kind of approaches that I am trying to provide in the paper. I think there is a complementary role of nomothetic, nosological approaches and ideographical or narrative approaches. And finally, I would say that in this paper, we try to postulate that narrative practices integrate the resources of ideographic and nomothetical resources, providing an opportunity to study the dynamical fluctuations in phenomenal experience, its temporal structure, and the contextual, relational, and developmental features. And I think that dialogical storytelling is key to achieve a gradual reappropriation of the sense of authorship in patients who have been perplexed by the randomness and heteronomy of their lives. Finally, I think that dialogical storytelling is facilitated by psychotherapy, and this may be conceived as Dr. Stanginelli does as a dialogical process that facilitates the agential capacities in ecological setting of the patient. But finally, I would also try to say, following once again Paul Ricoeur, that even if we try to make a reconstruction of the sense making, the meaning, and the values of our patients, we need to maintain a sense of modesty by recognizing the impossibility sometimes to achieve a complete and definitive restoration of meaning in every circumstance of illness and disease. And this is because the organic composition of the body perhaps is not fully reducible to semiotics and semantics. So, well, this was the presentation. Thank you very much for your kind attention.
That was wonderful. So I think we can start off with the Q&A. I see that we have two questions already. So anyone else who would like to ask a question, please feel free to raise your hand. I know that I have a few. That was absolutely fascinating and a real tour de force. But we'll start with the chat. We have Michael Young, and if you want to mute yourself, you can also do that. Otherwise, I'll read your question.
Thank you. Thank you for the brilliant talk. I had two questions. The first was, given the challenges of incorporating first-person experience into neurological practice in particular, which has been increasingly shaped by objective so-called biomarkers, localization, or imaging, what steps practically might we take to ensure that phenomenology can meaningfully inform diagnosis and treatment, if at all? And my second question was a more specific question around functional neurological disorders. It was mentioned that it might not be the preferred terminology, and I wondered if you could expand on that. Thank you.
Okay, so I'll make a very brief comment on your second point. Thank you very much, Dr. Jung, for the questions. So I would say that I have some sense of skepticism, perhaps, to this term, the functional neurological disorder, perhaps because I'm not fully convinced that these problems are neurological disorders, but perhaps you are a neurologist and you can persuade me. No, but I mean, I'm not trying to challenge you right now to do it. No, of course I need to go through the whole literature and read a lot about this. I must confess that I feel very with a lot of uncertainty myself when I have to care for these patients, which I do, and I try to follow the steps, but I don't think we have the understanding of these conditions. And my fear perhaps is that we try to make some kind of closure with the resources in a way that we think that we understand, but perhaps we don't really understand so far this problem. But I must say that my comment is really superficial, because I am not a full scholar researcher of functional neurological disorder. I have just seen the changes in terminology, and I am not arguing for a more conservative. Of course, I would reject the category of hysteria, right? And I was not fully convinced either by conversion disorder, but I think there are some psychological processes there that shouldn't go out of the picture, so to speak. No, and that doesn't mean that there are not important functional neurological processes as well. So I'm sorry, I know it's not a satisfactory answer, but that was my opinion. I can comment on the other point that you were asking for. How can we ensure that the first person perspective gets into the clinical file, so to speak? So I think that the most important thing to do in that case would be, I would rely on one of my teachers, Dr. Stan Kutcher from Canada, told me once. I had a difficult patient, so I made this consultation with him, and he just told me, spend more time with the patient. Spending more and more time with the patients sometimes will give more opportunities to actually listening to the patient. We need some conditions for subjectivity to arise, right? And I think that the old traditions of phenomenological psychopathology have some resources there, right? Of course, I would argue that we need to make a very rigorous neuropsychological assessment. I'm a fan of clinimetric approaches as well, but I think that we need to spend more time with our patients to if we really need to capture their subjective experience, and we need to, because as said before, many of our clinical phenotypes in cognitive neurology and neuropsychiatry can only be captured through the approach to subjectivity, right? Like symptoms like confabulation, delusions, anosognosia, and so on. We don't have even neurocognitive measures to quantify these symptoms, right? So thank you very much for your questions.
Great. And we have a raised hand, Dr. Tolchinsky. Feel free to unmute and ask your question.
Thank you so much, Dr. Ramirez-Bermudez. It's nice to see you finally in person. We corresponded, and you were so nice to be a reviewer for one of my papers, which I'm most grateful for. I wanted to maybe ask you, as we talked about, and maybe bring it up, that narrative is a double-edged sword where it has many, many benefits, but it also has some pitfalls and caveats. And specifically, if we were to take a metaphor, if I'm looking at the waterfall, which is a dynamic and turbulent process, and I take a picture of it with a camera, it becomes static, And I think that when we use words to describe clinical phenomena, we use deterministic objects. Every word is a coarse graining of what's going on. It's a semantic category. Say apple is a category, right? So we slow down in time, and we lose a lot of nuance and details when we use words. And then we stream words together in sentences and in paragraphs. And this phenomenon of narrative fallacy, when we sometimes connect the dots, well, we don't, strictly speaking, have information that the dots are indeed connected. And so in neurology, in your practice, when you use something like an EEG, you look at dynamic data with a time resolution of seconds. But when you hear a patient's first-person narrative, then you are dealing with perhaps, time scale of maybe months when they tell you something that they recall. And also we're dealing with memory distortions. Let's say the patient wakes up or, tells a therapist a dream in a session. The story about the dream and what they saw in a dream are two different things. So I'm just wary of this difference. And I think that if we augment narratives with other tools, other sources of information, such as, I don't know, perhaps EEG or galvanic skin response or, video camera in the room for some conditions that require us to get dynamic information, then we will get a chance to evaluate the patient in less deterministic fashion and be open to nonlinear dynamical systems approach to what's happening with a patient and draw a movie of attractors and repellers fluctuating more so than a page of text which explains everything that happens with the patient. What do you think?
I think it's a very important consideration. First of all, I'm very glad to see you. Also, it was a very good paper, that one that I had chance to review. And yes, I've read your work on the narrative fallacy, as you call it. I think it's a very important criticism of any strong thesis about narrativity, right? In our own paper, because of time, I didn't went into this in this presentation, but we dealt with two objections to this sort of thesis on narrativity, right? The therapeutic approach through narrativity. So there are two objections that I think are very important. One is an argument by Strawson against narrativity that is somewhat close to your own approach of the narrative fallacy. And I think that we, especially as clinicians, are aware of the distortions in memory, our cognitive biases, or our defense mechanisms, if you want to use that terminology. I think all of that is very important. And of course, we don't need to, so to speak, to buy at face value any kind of discourse from ourselves or from our patients, or if we are in the position of being a patient, we also ask for our clinicians to have a critical eye on our discourse, right? And that's part of the work of being a clinician, not being always just validating the discourse of the patient, which I think is not a good, mature procedure in psychotherapy. Although, of course, there are moments to validate, right? But I am completely in agreement with you regarding that objection. And I think that only through the resources of a third-person perspective that can be, of course, informed by electrophysiological brain imaging technologies, and in fact, any kind of resource from a third-person perspective will allow us to have a more multilateral picture of one problem, right? But the other objection is equally important, and it is the objection formulated by Kenneth Kendler, the very bright psychiatrist and philosopher, which he calls the trap of meaning hypothesis. No, so, and he formulates that when we engage in hermeneutical traditions, whatever this is, no, it may be feminism, it may be Marxism, it may be neuroscience, it may be psychoanalysis, any tradition. If we engage long enough with these traditions, we may have a bias, and we may start interpreting everything through that lens, right? So we need also to, I think this is where the dialogical storytelling becomes important, but most importantly, the transepistemic and pluralistic approach, right? Because sometimes a colleague will correct me, or my clinician, or even my patient can correct me at times, or a philosopher, or a scientist from another field. So I need to have this spirit of openness to criticism, because otherwise I can be prisoner of this trap of meaning problem, which is, I think, one of the worst in the field of mental health.
So well said. So well said. I think, I agree that as clinicians and as human beings, we need to really see multiple ways of parsing out reality. I thought that was brilliant. Anyone else interested in asking a question, please feel free to raise your hands. You're raising your hand.
I have a question, if possible.
Please.
If Dr. Michael Young or Dr. Alexei Tolchinsky want to provide a reply to whatever thing that I said, I would be very glad to hear them. Of course, if we still have some time, or there's no much pressure from other speakers.
Absolutely. Feel free to raise your hand or unmute.
Thank you for the reply to my questions. On the question about functional neurological disorder, I didn't have a particular position that I was advocating for. I was, curious to hear more about how you were thinking about it, as it is one of those diagnostic categories that really is spanning neurology and psychiatry, and perhaps one area where phenomenology might play an even bigger role than some other areas in neurology where diagnosis can be more prototyped. And really appreciated your insights on how to begin integrating phenomenology into clinical practice. One of the challenges that I see is that as our nosology becomes increasingly intertwined with biomarkers, whether that will push out the opportunity for allowing subjective experience to shape how we think about disease and disorder. So I really appreciated your insights on that.
Dr. Tolchinsky.
Yes. I also am most grateful, and I think specifically with thought disorders and psychosis, that this narrative analysis is extremely valuable. And but I wanted to maybe contextualize where I'm coming from. I think in the field of psychiatry and clinical psychology, sadly, I think determinism reigns supreme, and nonlinear dynamical system and chaos theory are at the margins. Unlike clinical neurology, I think that chaos theory is used to, detect seizures on EEG right now, and in cardiology. And my problem is, I'm quoting William Sulis and other colleagues, that mental health phenomena have emergence, contextuality, and transience. And our diagnostic systems don't account for that as well. We use buckets still, continuous buckets like autism spectrum disorder, categorical buckets like major depressive disorder. Perhaps it affects maybe neurology as well. And this is how we think. That patient walks around and says, I have depression, I have major depressive disorder, versus, again, looking at it as a flow, as a dynamical thing. And so I think that if we consider the tools of conceptualizing the case that are fitting these dynamics, then I think that we can do better by our patients. And they may not fit into a story form. I think story form is very convenient for us humans because we have working memory, and our minds are storytelling minds. We're optimized to hold in memory sentences. Our span for sentences is double as compared to span for fragmented pieces of data. So it is less effortful for us as clinicians to process data in the story form. We're not thinking probabilistically, we're not thinking in movies and images. But if we embrace that in our diagnostic rooms, I think that we can possibly get even better with our patients.
Yeah, and I will take the opportunity to sort of continue asking a question from where Dr. Tolchinsky left from, which is we talked a lot today about the role of narrative, and narrative is a literary form in its own right. And kind of going off of the limits of narrative, I wanted to ask you, what do you see as the role of alternative literary forms? Whether that's, poetics would be one, and then alternative ways of perceiving reality through art, whether that's through um, to pictures, to films, and through other artistic forms. I understand that's sort of outside of the narrative, but what other forms do you see as relevant, Dr. Ramirez-Bermudez?
Yeah, thank you very much for the question. So I am biased because I come from a family of artists and musicians and writers and painters. So I would advocate for any form of artistic work. I think it has a therapeutic role, although I don't want to overemphasize that because uh, I don't think I don't think we have any form of miracle through arts or through through anything. In fact, no, I think we need to remain always on the reasonable side of scientific skepticism, perhaps, no? But I think that all forms of artistic, for instance, the narrative arts beyond literature have an important role. I have colleagues who work through photography, for instance, no? And it becomes an important tool for their therapeutic work. Of course, music is one of the most powerful resources for our patients or for ourselves, no? And the visual arts also have this potential. But what I think is more interesting to me, at least, is that through arts we can study the same kind of cognitive and affective processes that are involved in psychopathology, but perhaps there we have the most flexible forms of sense making and creation of images and conscious experience and activity. So I really think that we need to study all those processes to have a more complete picture of the neurocognitive resources that are somewhat being affected in psychopathology. And so I think that the full picture requires this approach to arts, right? So I would advocate for that kind of resources, and on a personal level, I think I'm trying to develop a program of neuroscience and music because it becomes a tool to map some processes in my patients that are not being mapped through other resources, right? Like we have language for the left hemisphere, but some patients, perhaps we are not capturing their functional problems because we are not exploring, so to speak, rhythmic structures or melodic structures and so on. So that is a personal interest of mine.
Yeah, and what I was also curious about was sort of, if you were to think about narrative as a hermeneutical tool that's linked to interpretation and cause and effect in how we build our own narratives, whereas other art forms may be less constrained by the principle of non-contradiction or by temporality, if you will. There's more freedom in them.
Yeah, it's a very, very interesting and important question. I would say that there are conceptual resources, so to speak, semantic resources, probably in most of the arts, even in music, that which seems non-conceptual, but when you speak to professional musicians, they have a system of symbolization and they have their own conceptual resources to describe musical experience and musical creation. But perhaps the semantics of music, for instance, may be semantic dimension closer to affectivity and emotions. So that is, for instance, one avenue of research which is really interesting, right? Because when we explore affectivity through literature and verbal language, it always comes in a way through the through the tools of language, which are perhaps limited, right? But also, when we study literature, there are important paralinguistic, musical resources, rhythmical resources that are also there, no? So I think that all of the arts have these dimensions. Of course, the case of visual arts has the features of color, right? Which can only be approached in literature in a sort of mnemonic or metaphorical way. Only the visual arts can give us that quality, no, that phenomenological quality. So I think each of the arts has its own resources for research, neuroscientific research, and also for instance, neurocognitive rehabilitation or for psychotherapeutic practices, right?
Absolutely fascinating. I'm curious to see if anyone else has questions. Galina, take it away.
Thank you so much for this incredible talk. I feel like I have so many ideas going in so many directions. It's hard to even know where to start, but I had one comment kind of question and a follow-up question. So the first comment is I was really struck by the idea that you discussed in the sense of using narrative as like a authoring process to like re-agentify an individual, particularly within psychoanalytics and psychiatry. I definitely see that, you know, we talk a lot about the talk therapy, and I'm wondering if you see a sort of parallel in the neurorehabilitative space and sort of the motoric agency and kind of like the motoric authorship. And I'm wondering if you might just comment on some of your thoughts. I'm particularly thinking about this because I am a neurologist similar to Dr. Young, and care for a lot of patients with functional neurological disorder, and actually find that one of the features of my experience, not in all examinations, but in some, is actually observing sort of the discrepancy between the subjective, their subjective experience and then my objective exam, and then sort of sometimes the authoring of like re-agentifying them as, for example, in the case of a case of functional weakness, of like them as the agent capable of moving the leg, you know, that isn't moving itself, and sort of like any case, just curious if what you think about incorporating that kind of narrative into rehabilitation and how we can do that if that's been looked at. And I'll start there, and if there's time, I may have one additional question.
Yeah, well, I have one of the co-authors of this paper. Unfortunately, she's not here today to give you a better answer than mine, because she makes research on choreography and dance with the resources of neurodynamics, no, through EEG and the statistical analysis of the signals. But she explores this the dimension of agency through choreography and dance. And I think that would be a very powerful metaphor or conceptual resource to approach neurological rehabilitation. I guess that you're talking about sensory motor patterns, right? Sensory motor patterns. So I think, yes, it would be a great case for this kind of approach, not through verbal narrative, although of course verbal narratives can provide a way to have a conceptual map of what's going on, but perhaps what's going on is this appropriation, no, of the sense of agency of your own sensory motor patterns, right? Which is perhaps pre-linguistic, although of course verbal behavior may allow for some sort of process of feedback, no, that may be also therapeutic in a way, perhaps.
That's such an interesting point. I'll just share one short anecdote, which is I participated in a dance workshop for neurorehabilitation, and part of the exercise, it was patients and clinicians dancing together, was mirroring. So it was the idea that one partner followed the other. And I was paired up with an OT physician, OT practitioner, occupational therapist, and was, moving my hand, and she was following, and she was like, I wonder why we don't do this in the clinic. I have a great sense of your range of motion, and I didn't even lay my hands on you because I saw, as you, pronated slightly like in that direction, you were able to have this full extension or not. So just a really interesting, both of us had a lot of gear shifts that day. My follow-up question is actually related to the education of a new generation of practitioners. If we want to have providers who can create the kind of space for phenomenology and subjective histories, do we need to be training physicians differently? Do we need to have them reading narratives so that they can understand the story, that the patient is telling? I love how you said about we need elements in place to allow this phenomenology to come through. And so if one of those elements that we potentially have an opportunity to have action on might be, how do we prepare our future clinicians for this type of work? What are your recommendations for the training of future, let's say physicians, but I would say all healthcare providers?
Oh yeah, definitely. Yeah, I would advocate for this kind of approach, but I mean it's kind of paradoxical because I'm also in the business of education, in my own hospital. So on one hand, we want clinicians, neurologists, psychiatrists, neuropsychologists, and so on, to be technically very, very competent, right? So we need to emphasize that part. But I get worried sometimes when my own, for instance, psychiatry residents seem to have forgotten part of the tradition that I thought that it was so well established in my hospital that they would know it for sure, right? And so sometimes I find myself, for instance, um, making a defense of psychiatry, saying that no, psychiatrists are never so square as to be only relying on the DSM and whatever. No, I make those kind of emphatic defenses with a lot of sentiment. But then I go to the clinic and I see some of my colleagues doing exactly that kind of approach, not listening to the patients, not knowing the history, not paying attention to the histories of learning, histories of interaction, contextual processes, and so on. And well, of course, I get disappointed. And so I think that I need to emphasize that part once again. And the same goes to phenomenological psychopathology, for instance, because sometimes some of my own colleagues, which are very bright researchers, were telling me that, well, the age of mental symptoms and that kind of speech was gone. Only now we have MRI, functional MRI and spectroscopy. And myself, I did my PhD with that kind of resources. But if we don't have a good clinical approach to neurocognitive phenomena, the subjective aspect of it, or the behavioral aspect of it, or the cognitive aspect of it, we don't have a phenotype to be explained in the model. So we need to develop the explanandum, so to speak, what we need to explain, at the same time that we develop the explanans, or the explanation, right? So if the explanation is going to be a neurocognitive explanation, either way, we need a full account of the explanandum, which is the clinical patterns and so on. That's my point of view.
Wonderfully said. We have time for maybe one more question. As you can tell, everyone loved the talk, so we have so many questions. But in the interest of your time, we can take one more. And we have Dr. Thomas.
Thank you. I'm a neurologist. I've worked with a narrative arts program for people with MS some 15 years ago, and currently we have a medical student who's actually quite well-known poet working with MS patients in creating their narratives. In 2015 and 2018, I published some papers on the Marianic miracles published by Berciano and at the court of Alphonse El Sabio in the 13th century. And I was wondering also, and when you show that first narrative of a patient who saw himself in a very complex fashion, I thought a little bit about how in current times people see themselves as the last generation, reluctant, some people, reluctant to have children because the world is ending. And from the Marianic miracle publications, I learned about how religion plays into the phenomenology. And I was wondering how you listen to that in your patients' stories. Not just religion, but any kind of spirituality, and how that helps you understand patients.
Well, okay. First of all, thank you very much for this important question. I would love to read your own works on this. I will ask Mattia Rosso if he can help me to get those kind of texts, because I would like to read them. I'm interested in genuinely curious about it. But on your second question, I pay a lot of attention whenever possible to the symbolic landscape, so to speak, of the patient's life, whatever that landscape is. And many times it's a spiritual or religious landscape. So even if it's not part of the central axis of the discussion with the patient, of their clinical problems and so on, it always helps me to have this kind of affective attunement. Even if I don't uphold the beliefs of the patient or whatever, because most of the time I won't. But just listening to it and knowing about it makes the patient feel that I know him better. So I think this is the kind of thing that creates the opportunity for a more genuine subjectivity to arise. So once that that situation is created, I'm always very curious of this spiritual life of my patients, even when it's completely related to the psychosis of the patient. But this is almost a research question. I am very interested in which ways spirituality and religion modify, for instance, psychotic patterns, the content of delusions and so on, and in which ways delusions modify spirituality. Because I don't think it's a full. I don't think we have a full picture of it. There's of course school of thought coming from existential traditions and so on that has explored that, but I don't think we have a full account of it. So far, I would say that it provides a tool for the clinical approach.
Thank you. I sent you a message with the references.
Thanks a lot.
Well, I have to play bad cop to Mattia's good cop and step in to end this discussion. It's one of the hardest jobs I have to do, but Dr. Ramirez-Bermudez, I think the fact that we have gone over time and still our questions aren't answered is really just a sign of the richness and value of the work that you've done, the questions that you've raised today and what you've shared. And I think I know I'm leaving with about 100 questions unanswered, but that's a good thing, I'm going to say in this case, to keep pondering and keep thinking. So just want to say thank you again for joining us this evening, and thanks everyone for your questions and the too short but nonetheless extremely valuable conversation at the end. I'll ask Mattia to just put up a slide to talk about our next plans for the rest of the month, and we're just really hoping that you guys will continue to join us. As you know, in between our seminar lecture-based talks monthly, we are offering booster sessions. These are practical approaches to have a hands-on experience with the arts and humanities. We're extremely excited next week to welcome Jonathan Duskin, critical care fellow extraordinaire, but also chef, who is going to be really diving into the culinary arts, the idea that there's an art to and culture to cooking. There's a humanitarian component and a component of bringing people together socially, and there's a health component. So he'll be doing a test kitchen demonstration and discussing about nutrition and brain health. And then in March, we are very excited to turn things back over to the visual sphere. We're going to be welcoming Dr. Osama Khan, who also, I guess this is a neurocritical care double duo, also neurocritical care trained physician who's now doing an epilepsy fellowship and is a artist. He is someone who has painted a lot of expressions of neurological conditions to kind of represent the patient experience through art, and actually was recently featured on the journal cover of Neurology Clinical Practice. You can see one of his paintings on prosopagnosia actually depicted there, and you can read a little bit about his work and hear him. And if you happen to be in the US and heading to AAN, he's going to actually have a Q&A and kind of demonstration and visual show a little demonstration at the conference there of his work. So if you can't catch him online, maybe you can catch him in person in April. And with that, we wish you a wonderful evening. Please send in your recommendations for speakers. Please give us feedback on the little form as you log off. And we hope to see you at our future sessions.
Thanks again for the wonderful session. Have a good night, everyone.